Hello, I'm U.S. Representative Benny Thompson of the 2nd District here in Mississippi and chair of the Congressional Black Caucus Institute. Welcome to the 21st Annual Mississippi Policy Conference. It has been my esteemed pleasure to welcome each of you to the Mississippi Delta for the past 20 years. This year's conference, which we get to participate in from the comfort of our own homes and offices, is extremely critical because of the challenges we are all currently facing with COVID-19 and a renewed spotlight on police brutality. Though we are not in the Mississippi Delta this year, I still believe Tunica represents progress and what's possible. That's why every year for 20 years, we've returned to Tunica to be reminded that while progress has been made, much remains to be done. We believe that staying informed on the issues will inspire change and ignite all of us to action. We hope you'll join us in transforming communities. Thank you for your support of the Congressional Black Caucus Institute, and welcome to the annual Mississippi Policy Conference.
Thank you, Chairman Thompson. Good morning again, everyone. I am Vanessa Gradine-Jones, the Executive Director of the Congressional Black Caucus Institute, and welcome again to the 2021 Mississippi Policy Conference. Black in America, a public health crisis is this year's theme. In the first few months of 2020, we began grappling with an unfathomable global pandemic, and as a result, the glaring racial health disparities that exist even within a virus that impacted the entire world. But we were also, in the worst way, made aware that this virus wasn't the only public health crisis we were facing. Just as governors and mayors were orchestrating reopening phases, an unarmed Black man, George Floyd, had the breath of life forced out of him by the knee of a white police officer for 9 minutes and 29 seconds. An all too familiar conversation reemerged front and center about the value and worth of Black lives. At this time in our history, the convergence of these two pandemics drove people of all backgrounds and ethnicities to the streets in protest and rioting, begging the question, how do we bring about sweeping systemic change? There are multiple systems, practices, policies, and thought processes that must be reformed. And today, with today's panel and tomorrow's panel for the conference, we will explore these. Now, I would like to introduce a video for a special conversation as we kick off this panel with Dr. Anthony Fauci and Chairman Benny Thompson. Thank you.
We're pleased to bring virtually Dr. Anthony Fauci to Tunica today. As the director of the National Institute of Allergy and Infectious Diseases, he's been leading the fight against COVID-19 and working to combat misinformation around the diseases and vaccines. And CBCI is proud to be part of the COVID-19 African American Education and Outreach Partnership, which is working to fight COVID-19 in African American and rural communities. This unprecedented partnership between CBCI, Kaiser Permanente Community Health, the East Bay Community Foundation, the National Minority Equality Forum, and 12 key community-based organizations seeks to address needs of communities that have been disproportionately impacted by the COVID-19 pandemic. We know that it will take all of us working together to finally defeat the virus and get back to normal. Dr. Fauci, thank you so very much for joining us today. We appreciate you answering a few questions and helping clear up some confusion around COVID-19 and vaccines.
Thank you, Benny. Thank you. It's good to be with you. I look forward to the discussion.
Well, thank you very much, Doctor. Right now, our national vaccine rate is about 50%. If we stay at that number, what does the next 6 months, year, and beyond look like? And what does the vaccine rate need to be for us to get back to a pre-pandemic level?
Well, if we stay at only 50%, and that means if you look at the entire country, we have, not counting children, the children who are not eligible yet to get vaccinated, there are about 93 million people in this country who are eligible to be vaccinated who are not vaccinated. That would be, I think, terrible, Benny, if we don't do much, much better than that. We want to get the overwhelming majority of the population vaccinated. We don't know what that exact number to completely crush the virus, but we've got to get way up there, 75, 85 to 90%. Likely we're not going to get that high, but we've got to do significantly better than 50%. And the reason is we have a vaccine, Benny, that is really quite good at protecting you from getting seriously ill and dying. 615,000 Americans in this country have died of COVID-19. That's the worst epidemic of a respiratory disease that this planet has seen in the last 100 years. There are elements of that that are really important, and that may relate to some other questions you have, but let me jump on it right away, is that disproportionately, African Americans are suffering from this from a number of standpoints. They generally find themselves in positions of their own jobs, their employment, that make them what we call essential workers in the community. So they're out there. They're not generally behind a screen Zooming like you and I are doing, which puts them vulnerable to get infected in the first place. And then, because of so many conditions that African Americans have been under regarding the social determinants of health, they find themselves with underlying conditions that make them more susceptible to get seriously ill and dying. So when you look at an African American person who winds up getting infected, hospitalizations among them are greater than among the general population. Deaths among them are, again, the general population. So if ever there was a group of people who should have easy access to vaccine, acceptance of vaccine, and getting vaccines that they could get really easily, it's the African American population. Everybody should, but particularly African Americans, because of their vulnerability for so many reasons. And yet we know the vaccines can really protect them. That's what we need to do, Benny.
Yeah, and I'm glad, Doctor, you talked about that, but so much of the reason in the African American community is this vaccine hesitancy. People talk about the Tuskegee experiment. People talk about on the female side, well, it might make me fertile or infertile, so that I might not be able to bear children. So for those misconceptions that you hear out here, what would you say to those people who are hesitant?
Well, the first thing you want to do is you want to respect them and the fact that they're hesitant, and not point fingers at them and say, let's talk about why you are hesitant. This issue of the Tuskegee experiments, they go back decades before many of the African American people in our country were even born, but yet it's passed down, understandably. It was a shameful episode in our history of doing that. And so you understand why people have concern, but you explain to them that what we have now are safeguards in place, independent boards of ethics and others who would never allow something like Tuskegee to happen again. Number two, well, what about the misinformation and disinformation about infertility, about things like that? If you look at the data, Benny, we've now given it to hundreds of millions of people throughout the world, including over 160 Americans have been fully vaccinated. There is absolutely no indication whatsoever that it has any negative impact on fertility in either a man or in a woman. But yet, the disinformation is out there, it spreads on the social media, and it has the extremely difficult negative effect of preventing people who really need the vaccine from getting it. We all know I got vaccinated. My entire family's been vaccinated. My children have been vaccinated. I feel perfectly comfortable with that.
Well, thank you very much. And likewise, my entire family has been vaccinated too. And so we tell everyone the alternative to not getting vaccinated is a risk I don't want to put on anyone. So I hope people continue to listen. Well, also, Doc, we're right in the middle of kids going to school or starting back to school. My grandson went to school last year, all virtual. This year he's going back. His particular school has a mandate that all children will wear masks. The teachers will either have to wear a mask or get tested every week. What kind of direction can you give to the parents who sending the children to school and for those individuals who might be working in school systems?
Right. Well, you want to get the children back in school physically because we know of the detrimental effects in mental health and social development and so many other things if you keep them out of the classroom. But if you bring them back into the classroom, you've got to do everything you can to protect them. The first thing you do is you surround them with people who are eligible to be vaccinated and make sure they get vaccinated. You know, the head of the teachers union has said even that very much so is in favor of mandating that teachers get vaccinated. And, you know, obviously that's something that's going to be very important. For the children who can get vaccinated, those who are 12 and older, you should get them vaccinated. Then when you get as many people vaccinated as you possibly can, then you want to protect the children even further by saying, if you're going to come to school, you're going to have to wear a mask, and everybody should be wearing a mask. In fact, the CDC recommends that everybody in the school wear a mask, even those people who are vaccinated, to safeguard the children. Those are the things you want to do to make sure that your grandchildren are safe in an environment so that they could learn in person in the classroom and still be safe.
Thank you. Well, and you were talking about the CDC guidance. I understand there's some new guidance out on the kind of mask that they are recommending. Can you talk a little bit about that guidance?
Well, you know, there's not guidance on the kind of mask. There was an issue about N95 masks. Do you really need to wear N95 masks? We're feeling now that if you wear a typical surgical mask, you know, sometimes people, in order to make it fit well, you know, they put a cloth thing on there so it fits much better. But rather than getting hung up in what kind of mask you want to wear, just wear a mask, whatever the mask. You know, I have multiple kinds of masks.
I got one right here.
Yeah, exactly. I mean, I have them all over the place. I mean, I don't have one now because I'm not with anybody. But
right.
Let's say here, you know, you got all kinds of masks. We recommend that if you try and get people to be wed to one particular type of mask, they're not going to wear a mask. Just do one thing: wear a mask, and then you're okay. If everybody wears a covering like this, we'd be much better off.
Yeah. Well, you know, I think The masking is important. The social distancing, washing your hands, all those things that most of us have come to live and learn by becomes the order of the day. So, if there's a parting comment you'd like to say to our audience as this pandemic continues to grow, what would that be, Doc?
Yeah, that would be the message about what essentially you've been saying and I've been saying in a concise way. If you are eligible to be vaccinated, please get vaccinated. It will prevent you from getting sick. It will prevent those around you in case you get infected and you don't even know it. So it's not only about you, it's about your responsibility to your community, because vaccination not only protects you, it provides a blanket of protection because it doesn't allow the virus to use you as a vehicle to spread it to somebody else. Now, some people say, well, I don't care. I'm young, I'm vigorous. So if I get infected, I'll worry about it. I want my freedom. It has nothing to do with freedom, Benny. It has to do with protecting yourself, protecting your family, and having the responsibility to protect your community. We got to take it out of the context of freedom or not. We're dealing with something that's killing people at a really high rate.
Yeah, and thank you very much because there's been so much, as we talked about, that misinformation and I even had somebody tell me recently, say, well, you can just go to Facebook and you can find out all these problems with the vaccine. And I said that's not the authority you should be relying on for direction in this pandemic. But so many people are wedded to social media, as you said. So we would want to encourage them to follow the health professional guidance and not what you find on Facebook, because the majority of what's on there is not the official position of our health professionals.
Right.
Is that what you would want them to
Yeah.
to do?
Yeah. I mean, the information you want is so easy. I mean, if you have access to Facebook, just go to cdc.gov and you'll see all of the information that has accumulated on the basis of good science. That's what you want to do. I mean, the best way to counter misinformation and disinformation is by what I say, flooding the system with correct information. And that's the reason why I so willingly am enthusiastic about talking to you and your colleagues.
Thank you very much. And let me again thank you for giving us your time for the Congressional Black Caucus Institute program. We will run this weekend, and obviously it'll be available for the future. But again, thank you very much. And again, please stay well.
Thank you. You too, Benny. I appreciate you having me. Thanks a lot.
Thank you.
Thank you, Dr. Fauci and Congressman Thompson, in our fight against COVID. Now I'm turning over to our start of our panel. Moderating this afternoon's panel is Dr. Natasha Lee. Dr. Lee is Vice President, Social and Clinical Research and Development at the National Minority Quality Fund. In that role, she is responsible for the oversight and implementation of research projects and programs focused on reducing patient risk and identifying optimal treatments to reduce health disparities and bring about health equity. Prior to joining MMQF, Dr. Lee was with the Sickle Cell Disease Clinical Trials Network. Dr. Lee is a deeply knowledgeable scientist and public policy advisor with experience on Capitol Hill. Thank you for joining us today, Dr. Lee, and I'll turn it over to you for today's panel exploring the desperate impact of COVID-19 pandemic on the African American community.
Thank you so much, Vanessa, for the opportunity to moderate this very important discussion. As you stated earlier, and the remarks in the earlier panel, the disparate impacts that this COVID-19 pandemic has had on communities of color, in the words of Dr. Fauci, has really shined a bright light on healthcare, health disparities, and health inequities in the public realm. And these health and healthcare disparities aren't new. And so I'm really excited to have a really impactful discussion with our amazing panel. I'd like to take the opportunity to introduce them one by one. So the first is Althea Jackson. So Alethea Jackson is a highly experienced public health affairs, government relations, and community executive with over 20 years of success at the Walgreens Corporation, as well as America's Health Insurance Plans and the National Association of Insurance Commissioners. As Vice President of Federal Government Affairs and Head of Advocacy at Walgreens, Alethea is driving efforts to further progress the company's vision, purpose, and strategic policy objectives to expand patients' access to pharmacy services, advance the role of pharmacy within the healthcare system, and support retail growth and value creation. She chairs the cross-functional COVID-19 Vaccine Equity Task Force, working to ensure equitable distribution of the vaccine to communities of color. She is a native of Brooklyn, New York, and holds a JD from Syracuse University School of Law and a BA from the State University of New York in Albany. She currently resides in Washington, D.C. with her dog, Jack. Next is Dr. Gary Puckrin. Dr. Puckrin is President and Chief Executive Officer of the National Minority Quality Forum, formerly the National Minority Health Month Foundation. The NMQF is a nonprofit organization that he founded in 1998 that addresses the critical need for strengthening national and local efforts to use evidence-based, data-driven initiatives to guide programs to eliminate the disproportionate burden of premature death, preventable illness for racial and ethnic minorities and other special populations. The mission of NMQF is to reduce patient risk by assuring optimal care for all, strengthening the capacity of local communities to eliminate the disproportionate burden of premature death and preventable illness in minority populations through prevention, early detection, and control of disease complications. Dr. Puckrin is a graduate of Brown University, where he received his master's and doctorate degree, and has received numerous awards and honors, including being named a visiting scholar and fellow at the Smithsonian's National Museum of American History and a visiting fellow at Princeton. Next, we have Dr. Frida Lewis Hall. During her 40-year career, Lewis Hall has been on the front lines of healthcare as a clinician, researcher, and leader in the biopharmaceuticals and life sciences industries. As an award-winning advocate for health equity and improved outcomes for all patients, she provides advice and consumer health information on national programs such as Dr. Phil and the Doctors, and is a regular speaker at consumer and healthcare conferences. Dr. Lewis Hall served in various leadership roles at a number of pharmaceutical companies, most recently as Chief Medical Officer and Executive Vice President, and later Chief Patient Officer at Pfizer. Appointed by the Obama administration in 2010, she recently completed a decade of service on the Board of Governors for the Patient-Centered Outcomes Research Institute, also known as PCORI. She has served on numerous boards focusing on advancing health outcomes, life, healthcare, exact sciences, SpringWorks Therapeutics, the Foundation for National Institutes of Health, the Milken Institute's Faster Cures Center, and the Prostate Cancer Foundation. And last but not least is Dr. Fredette West. She's a steadfast leader in health policy and health advocacy. She's director of the African American Health Alliance and founded and chaired the Racial and Ethnic Health Disparities Coalition. Both organizations focus on and have committed to the elimination of racial and ethnic disparities in health and healthcare, the elimination of social determinants of health, therefore. She's also created and co-managed the DHS, so the Department of Health and Human Services Initiative, the leadership campaign on HIV and AIDS. Over the span of her career, Ms. West has held a number of key positions on Capitol Hill, including Chief of Staff, Health Policy Coordinator for the Congressional Black Caucus Health Brain Trust to former Congressman Louis Stokes, who I knew very well, and the Associate Staff to the House of Representatives Subcommittee on Labor, Health and Human Services, Education, Related Agencies, Appropriations. As the lead architect of the Congressional Black Caucus Minority HIV/AIDS Initiative, she was a key strategist and negotiator in helping the CBC champion for the Presidential Tuskegee Apology Congressional Medal of Freedom for the renowned civil rights leader James Farmer, and furthering healthcare reform efforts. She's been a recipient of numerous awards, including the Health Brain Trust Heroes in Healthcare Award and the Legislative Black Caucus of Maryland Award for addressing minority health disparities in healthcare reform. Welcome to you all. So we are no stranger to this topic. I believe, we've been dealing with COVID for quite some time now. It just seems like our new normal. But the history of the medical system in America is really fraught with blatant racism and abuse in Black and Brown communities. And there's been really a discussion about the huge deficits in the amount of communication between these communities and healthcare professionals. In what ways do you feel that the medical professionals can really make Black patients feel safe and respected and communicate more effectively to their doctors, not only during this pandemic, but after we get out of this current pandemic? I'll pass it over to you, Dr. Lewis Hall.
Yes, well, first of all, thank you for having me. This is a topic that I have great passion around and have been working on for the 40 years that I've been in the medical field. There are a whole range of things that we now know through research about the connectedness between patients and their healthcare team that they identify with. In fact, there's some data that suggests, for example, that Black men do better and have better health outcomes if they are being treated by Black male physicians. And the biases that have been a part of our system overall have had pretty significant effects. Cultural beliefs, if you would, and biases kind of creep into the day-to-day care that's been given. Longstanding myths like African Americans have high tolerance for pain and therefore may not need pain medications or interventions under certain circumstances. That we have lower intellect and therefore may not understand if someone tried to explain to us that we're not likely to adhere, and that we have lifestyles that we're willing to have increased risks around. And then if you add to that behaviors that have been demonstrated in studies that in many cases, white physicians, for example, speak to Black patients with a dominant voice, are often directive and less likely to ask Black patients their ideas and opinions about their treatment, and have less emotional connection with their patients. Those things begin to add up to distrust, lack of engagement on the part of Black patients in the system. So what do we do about that? It would be great if we were able to develop a system where you could kind of match. Unfortunately, the data tells us that Black physicians, and the numbers are about 5% nationally, which is far lower to fill the huge need if we were trying to get all Black patients to have all Black physicians. But there are a few things that we can do, those that are in practice on the front lines. First of all, we need to do some bias training to all physicians, and Black physicians can actually help with that. We can also do team-based treatments in our own practices, but also encourage those practices elsewhere so that it isn't just a physician that we're thinking about, but team members like nurses, nurse practitioners, doulas, and midwives, and so on. So there are a number of things that we can do, I think, to help create linkages with the providers that are currently providing care, make them more culturally appropriate, help with structural things, and engagement is critical. But I think we can teach that and learn it.
Thank you, Dr. Lewis Hall. I was really pleased to see the AMA's statement and direction and initiative to really address racism in healthcare. I think that that's something that we really must strive to reach health equity. So, as we continue to confront this COVID-19 pandemic, there has been lots of questions around ensuring that patients really are knowledgeable about not only the virus, but those practices to keep themselves safe. What comorbidities are really prevalent among African Americans that complicate COVID-19 that they should be aware of? Anyone want to take that one? I could pass it. I can answer part of it. I think, as we start thinking about the morbidity and mortality in our community, you think about things like diabetes and
Exactly.
cardiovascular health. What are some of those challenges that you think might help to get individuals more vaccinated and knowledgeable about why they must really?
But this is Fredette West, and thank you, but I'm not a doctor, thank you.
Mhm.
But I do appreciate it. And I think we have to look across the board. So many of these diseases, and we don't even look at obesity as a disease, but there needs to be assistance and help with that. But when COVID came about, so much of what we as Black America was going through was the response was like as though you basically brought this on yourselves. It's the kind of lifestyle you this, that. No, 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 no. We had diabetes, we had obesity, we had this, we had that, we had the other, but we weren't dying from them in record numbers the way COVID has taken us out. And we have to look at that, but jump in front of that and make sure that we are vaccinated, that we do still wear our masks, that COVID is real, COVID still kills, but the good news is that the vaccines work. Yes, we have Tuskegee and all the other harm that has been done to us, the excessive deaths, the excessive brutality, you name it. We've been through it and still going through it. But vaccinations right now are key. They work. We have to stop putting it off. And maybe it may not work for everyone because we can't always just blanket everything.
Mhm.
But if we have concerns and if there is a healthcare provider in whom we do trust, try to seek that out. Healthcare providers during COVID have to make themselves more available to the public in a way that they haven't had to before. We can't carry this burden alone, and we are not to blame for it. But we all have to do what we can to get each other well. This is the most important time in our life when we are indeed have to be our brother's keeper. My grandson is standing next to me now. Young African American male, wasn't staged at all. They just at grandma's this weekend. He has on his mask, not as a stage, but because I don't have mine on right now, because even though I've been vaccinated, I could transmit to him. We all got to help keep each other protected. I won't use all the time.
No, I think that's incredibly important to really talk about the next generation. I'm not sure what your grandson's generation is called, but there's been a lot of conversation about the young millennials who, really are vaccine hesitant, really refusing vaccines. But
Well,
there's been
he's
cases.
10.
Oh, he's 10.
He's 10. And honestly, our grandchildren that his sister's been vaccinated, 15. All of our grandchildren under 10 are saying, where's mine?
Oh,
Right.
great.
What are they waiting on for me? That's not right, Grandma. Where's mine? So you have a ready group, but it's got to be the right one for them. Thank you.
Thank you for that. And I think you really bring up the point of having continuing conversations in community. That's important. You as an elder speaking to him about, why you got your vaccine is important. And I wonder if that actually helped to sway him and his siblings to really want to have that conversation around vaccine and when they can become vaccinated.
And his parents are vaccinated also.
Wonderful. So you have a whole family.
We've been on
May
this
I put
journey a
an
long time.
exclamation point behind that? I think we focused a lot in vaccine hesitancy on mistrust. And yes, there's lots of rationale for mistrust. There are lots of uncertainties that we want to answer. Dr. Fauci did an excellent job, of course, in addressing some of those. But there's also social norms. One of the things that I hear often from people is, well, nobody that I know that looks like me that's in my community has been vaccinated yet. So I'm gonna wait until that starts to happen. So having family and friends know I got vaccinated, my husband is vaccinated, my children and all my eligible children are vaccinated is such an important point. So thank you for that kind of leadership, and helping to create the social norm about us wanting our vaccines and getting them as quickly as possible.
Just a quick one. We got to make sure, though, that we don't wait until it's too late. We can't wait till we are on that bed to say, I wish. But there's been enough documented now, and people have come out to say, at least before I leave here, I want you to know I don't want you in this bed like I was. I want you to get vaccinated. Those have to be played more and more, and they are real. And we have to stop saying they are stories. They are not stories. That's real life in real time.
So on this topic of vaccine, I actually want to introduce you, Carlos. So can I put a pin in that real quick? So Carlos is Senior Vice President and Global Chief Diversity Officer at Walgreens Boots Alliance. Since joining the company in 2017, he's been instrumental in advocating for diversity, equity, and inclusion at the center of all we do. Among his achievements are launching the first global Walgreens Boots Alliance Diversity Inclusion Report and the formation of the Global Inclusion Council, in addition to corporate value and inclusion and linking the proportion of incentive pay to performance in the diversity inclusion goal. He has partnered closely with divisions and functions within Walgreens as a champion for racial equity and the movement for affordable, accessible healthcare for all, regardless of post or zip code. Prior to joining, he served as Vice President of Sales and Accounts at Aetna and Vice President of Global Chief Diversity at COVID-19, a medical devices company, and has held several vice president level positions for Blue Cross Blue Shield, Safeco Insurance, among others. So with that, Carlos, please give your remarks around vaccines.
Well, I just wanted to comment on the other panelists. And first of all, thank you for allowing me to be a part of this very important panel. Thank the other co-panelists. And this is just important work that we all are just so committed to. I just wanted to comment on a few things that's already been said, but just take it a little bit deeper in terms of our role as Walgreens. We have been doing vaccinations, for a long time. I mean, when you think about the flu vaccination, shingles, whatever it is, we are out in the community. So some of the hesitancy, it's not all about hesitancy. Sometimes it's about access, information, and education. So what we've tried to do at Walgreens is really take a multi-pronged approach into looking at all of the barriers that's preventing people in our communities from getting the vaccine, whether it's hesitancy. So we want to give them the education, whether it's the message. And so we know sometimes it's not the message, it's the messenger, and making sure we got the right messenger. And then we also understand that we don't do this alone. It takes partnerships and collaboration. So we've partnered with organizations like the Urban League, the National Coalition of 100 Black Women, the 100 Black Men of America, Uber. We partner with Uber to give free rides to clinics so that we can make sure that all of the barriers that exist outside of people just being afraid, we try to remove those barriers. Since the vaccine has been available, we have gone across this nation setting up pop-up clinics. Right now, I think we are over 1,300 pop-up clinics across the United States in Black and Brown communities, in churches, at the Urban League centers, you name it, we've been there. If we haven't been there, we have plans to go there to make sure that we're providing access to all three of the vaccines. And we talk about the hesitancy. We talk about the Tuskegee study, which, if you think about that, one gentleman said to me at a town hall meeting, he said, you know what, with the Tuskegee experiment, they gave us medicines that was not right for us. And I had to correct and say, well, wait a minute, my brother, you didn't get medicine. They told you were getting medicine, but they didn't give you medicine. They gave you a placebo. Here, we're giving you the vaccine, and we're giving you education, and we're giving you messengers and examples of why this is important to you. So, with our 9,000 locations across the country, we've done over 28 million vaccinations to date. In Black and Brown communities, we've delivered over 10 million vaccines in medically underserved areas. So it's a commitment for us to do that. And I think we have to look at all of the barriers that exist and not just, hesitancy. There's so many things that are out there. I'll pause there.
Carlos, really, I want to thank you for highlighting some of the outreach initiatives that Walgreens has really done and led to help to combat COVID-19, particularly in communities of color. You touched upon a topic which really resonated in the fact that in many communities of color, there are what we call healthcare deserts. There's not access to a physician. There's not access even to a pharmacy. So thank you for doing those pop-ups. But one thing I also want to offer to the other panelists is, what is one way that we can continue to expand access to COVID testing and vaccination, especially in those underserved areas? We heard about what Walgreens is doing, but are there other opportunities for us to consider, trusted voices in community to really lead those conversations?
Some of that, I think, too, is meeting people where they are. I might not be near Walgreens or CVS, what have you, but believe it or not, I'm near Popeyes. Believe it or not, I do use the Dollar Tree store for my grocery store. So let there be pop-ups and meeting people where they are. Not a designation by a certain zip code, but if that's where I work, play, go, play, spend, meet me there. And don't have times that are 9 to 5. I'm not a 9 to 5 worker. I don't have that luxury. I'm before 9 and I'm well after 5. And in doing that, make sure that the people that are there providing the services are respectful of, doesn't look like they, or act like they don't want to be bothered with me, or I don't smell the right way, or look the right way, or hair isn't the right way. Meet people where they are, treat them respectful. Dollar Trees, look at how busy a Dollar Tree will be. And I'm not knocking anyone, because I go to the Dollar Tree and you never spend $1. Okay. But the first of the month, Dollar Tree is packed. Take advantage of those times. The only reason why I don't say where you go and cash your check, because I don't want anybody knocked in the head. So let's meet people where they are on a daily basis. And school-based clinics are really important. And the mental health our children are going to need as they go back to schools. You have some majority schools that have plenty of mental health providers already, but we have a shortage. And make sure we do something about the pipeline. We should not exit COVID and then with the next pandemic, because there will be one, that there's still a shortage of people that look like us that are healthcare providers and that healthcare umbrella workforce.
Ms. West, you nailed the you hit it on the head there. Dr. Lewis Hall also talked about the healthcare shortage that we're experiencing, and there's also this huge issue that we're facing with the primary care cliff that we're facing. We don't have enough primary care physicians to care for the future, and I think in order to address future public health crises, we must begin to build that. And I think it's not just that we need to have more medical schools, we also need more residency programs. You hear far too often that people aren't matching after completing medical school. That's a disservice not only to our nation, but to those in really underserved communities. There's not an opportunity for those individuals after completing their education to go on to residency programs. So thank you for highlighting that.
You know what you're pointing out? You're pointing out that there's a dysfunction in the medical training and the fact that you can't match up, and yet we say there's a shortage.
Mm-hmm.
Yeah.
Can I pull the thread on, because it's not just workforce
Absolutely.
training in terms of providers. Having been in the biopharmaceutical industry, if we want to conduct research, understand issues and attempt to address them, manufacture and deliver new technologies, we're going to need a workforce that reflects us, that helps to do that. And right now, I think there are many opportunities to amplify that. So I'll just give one example, which is the Unite program at the NIH, which is looking at biopharmaceutical research workforce and delivery of equitable kind of health sciences and healthcare. What do we do around that workforce? Pharma, as an example, is having a program at the end of October that's looking at graduate students of color, so a diverse group of graduate students, and not just PhD scientists and not just people that are often thought of as affiliated in the biopharmaceutical industry, but people who are in finance and law and engineering and digital sciences and data analytics. So it's kind of a wide open space. And I think creating pathways into healthcare service provision and healthcare service research and the entire ecosystem is really important for us to, kind of put our shoulder into right now.
Fellowships early on in the education process.
Yeah. Latasha, can I add something to that? Because I think
Sure, Carlos, go ahead. Go ahead, Carlos.
No, go ahead for that. I'm sorry.
Oh, I was just saying fellowships early on.
Well, I wanted to just say, and this is a healthy conversation, because when I think about, this problem as a whole, there are many facets to it and many different areas that we need to lean into. I'm sorry, I'm getting like a lot of feedback, so I don't know if it's me or, but there's a number of facets to this. And one, if you think about what this is really going to take to overcome all of this, is really partnerships. None of us can do this alone. And I don't want today to sound like a Walgreens commercial, right? This is not a Walgreens commercial, but what we have done and been very effective at is partnering with the community, partnering with folks like Dr. Lewis Hall and Fredette West, partnering with, as I've already mentioned, Urban League and other businesses. We don't want to say we carry the flag and we're the only one out there doing this, but we can lead the charge because of our reach, our breadth, and our depth, and our, in terms of where we're located and the ability, with 8.5 million customers coming into our store every single day, we can touch a large swath of the community. Okay. So it's going to take a multi-pronged approach to really address this, whether it's hesitancy, whether it's access, whether it's testing. Partnerships and collaborations are what's going to really move this forward. And folks saying, you know what, I'm not an expert in this area, so Dr. Lewis Hall, can you help me solve this problem? And what we're doing here is trying to lead with that. When we think about the shortage, 45% of our pharmacists are people of color. Mm-hmm. And they're in the communities talking to people that look like them, that they identify with, that they can speak the language. And when I say people of color, I'm talking about across the spectrum, not just African Americans, but across the spectrum. Mm-hmm. And so identifying with folks, seeing people that look like you, not challenging, but providing information and that trust and that guidance helps people to make that decision. The other thing is, at Walgreens, we are funding education for more diverse pharmacists and healthcare workers to come into the space, to go into those communities, because we know that has been a barrier. If you don't look like me and if I don't trust you, I'm not coming to see you. And healthcare is being delivered in non-traditional ways these days. Our pharmacists in many areas are looked at as primary care physicians. I mean, I don't want to officially put that title on them.
It is. It's true.
But that's where people are going to ask medical questions and, doctor, can you talk to me about this? So we have to have that trust and that presence in the community. So my overarching point here is this is going to take a comprehensive approach through collaborations and partnerships and all of us working together to solve this problem.
Could you mention a little bit about underrepresented populations of color in that cadre of opportunity?
Well, so you mean in terms of us creating pipelines and bringing people into it?
Yes, because you mentioned people of color, but the underrepresented. Right. This is Black America's time, so I'll ask in terms of Black America.
Yeah, I understand. Mm-hmm. So we are, in terms of, we have a partnership with Howard School of Pharmacy, right? Mm-hmm. We give over $1 million a year to pharmacy schools across the country to develop more African Americans, Latino, and diverse individuals to come into this space. And then we try and recruit, to the best of our ability, to recruit those individuals to come and work in our stores and in our operations. Right now, we have a partnership with Village MD, where we're going to be co-located across the country in over 600 locations with Village MD, co-located with the Walgreens. So you can go into this primary care facility, right, and then come into a Walgreens and get all of your care. And over 50% of those locations are going to be in medically underserved, socially vulnerable areas to provide that. So through education, funding scholarships, partnering with HBCUs, we're trying to take a very comprehensive approach to really trying to make a dent here. And it's only a small dent, but
you can make a bigger one. You can make a bigger one, because the fact that we lose so many of our Black boys early on in the education system, but yet the police system can find them like that. So we've got to jump in front of the train before you have to look for us in a museum to know what we look like.
Understood.
You know, Miss West, you hit the nail on the head with the black boys. So my father is a former legislator in Florida, and one of the initiatives that he launched really had to do with addressing health literacy. I'm sorry, just literacy in general. So literacy, if an individual has not met the marks by second grade, the trajectory for that young black boy who hasn't met those marks really can lead to devastating impacts on his future, whether it's not finishing high school, whether it's the prison to pipeline conversation. There's a lot there. And so I want to continue this conversation that we're on around the next generation. So I want to just share a bit of my story. So my father's family on that side, we came from an educationally disadvantaged background. My grandfather had a second grade education, my grandmother a sixth grade education, and my grandfather was illiterate. My father was the first to finish high school and went off to college on a PE scholarship. So I really always loved medicine and science. Went on to Florida A&M University, so if there are any rattlers out there, and I pursued science and went to Howard University for medical school, and then got my PhD in neuroscience. But I didn't have a support system really to guide me along the way. Can we talk a little bit about mentorship and how you actually get individuals at an early stage? I was a little fortunate later in my career to meet some very impactful individuals. I was part of a Lewis Stokes program that inspired individuals to go into the sciences through the Florida Georgia Alliance for Minority Participation in Sciences. And that actually led me to Capitol Hill as a Lewis Stokes Fellow on Capitol Hill to advise on health policy. But I think we need more programs like that. Congressman Lewis had an amazing history in legacy in creating these programs. We don't have that right now. And as we see that we're moving to a majority minority country, what should we be doing as professionals, as advocates, as leaders in health and leaders in legislation and policy to really advocate for a future of Black health in America?
As you said, reinstitute those programs and don't fund them at a failure rate. Fund them at a to succeed rate so that we aren't so dependent on just a few. And even as we look at that pipeline, look at that early set of, if they live long enough to retire from the professions. But some of those people are going to need to be brought back in even now as our children head to school and there's a shortage of healthcare providers, especially those in mental health, but across the fields and the related occupations.
I'd like to add, you mentioned science literacy. I think it is really important to capture the imaginations of children as early as possible. So encouraging science curricula in schools, exposing young people to, coding and doing things in video games is kind of exciting. I think, need to amp up excitement around biology and sciences and other dimensions that lead into health fields. And that is an opportunity for us to mentor and develop programs early. I have to share just a little tiny personal thing. I, like you, came from a background of educationally disadvantaged. And my father drove a taxi in the evenings in Washington, D.C. He knew every single museum and its hours. And so we would take a break on weekends and go to the medical museum. And, there I was, 7, 8, and 9 years old, standing in front of jars with body parts in them, mesmerized. And even though my father didn't understand that, and he wasn't a part of the medical profession, that stoked my interest. So I'm saying that to say, even if you are not in the sciences yourself, if you're not in healthcare yourself, there's an opportunity, if not an obligation, to help young people get inspired and curious about being a part of this. And then to the earlier point, been putting programs in place so they're not flailing around in their curiosity, but have a place to go, systems to be a part of that move them forward.
Thank you for
And
that.
my grandson here, Ben is 10, and Ben wants to be a scientist.
Wonderful, Ben. What kind of scientist?
I'm not really sure yet.
Not really sure. Well, you're still young. You still have time. I think that, there's definitely the need for more opportunities for our young Black children to really get into this field. There's so many spaces. And in order to address some of the issues of disparities and equities in care, we really have to inspire that next generation. There's been lots of studies around the concordance of care. So in ensuring that individuals, in the case of, or studies of individuals who are cared for by Black physicians, their outcomes prove better. That's been shown from cardiovascular all the way to obstetrics and gynecology. And I think that's important for us to recognize. So on the topic of medical professionals, we know that, we spoke a little earlier about racism in medicine, and we talked about the AMA's statement as well as some of the programs. But how do we reach medical professionals who continue to believe and perpetuate racist myths that hurt Black patients? Some of those racist myths are that we don't feel pain the same, or that our perceptions and knowledge on specific topics that are not equal to that of their white counterparts. What are some of those strategies that you think that we can do to reach those individuals? Or do we just have to wait?
Well, I'm not a physician, but for me, and I don't want to oversimplify it, but I think it's education and information again. I mean, I keep coming back to that. Cultural sensitivity training needs to happen in medical school and in these, early in their education as well. It should be part of the curriculum, and not just saying to folks, we're going to teach you how to dissect a body or to work on a body, but talk about the internal parts, the mental and the psychological pieces that go along with that, and how to interact with individuals from all backgrounds, races, sex, what have you, because, I've heard those myths. The other piece, and you may have already touched on it, but is the fact that, it's disparity in care. Some people may have great insurance, come from very wealthy backgrounds, but because of your skin color, when you go in to see a doctor, you're not given the same level of care. The quality of care is different. So how do so I think all of that comes with, the biases that exist, that bias training. And as a D&I professional, I hate the term unconscious bias, because I think there's no such thing as people know, biases exist. That may be the topic, but people know when they have preconceived notions about something or someone, whether you're a doctor, whether you're a DEI professional, whether you're a congressman. We have to learn how to control our biases and use them for good, because biases aren't always a bad thing. Sometimes bias can save your life, right, in the right situation. But at the end of the day, it's training. Sensitivity training has to happen early, cultural sensitivity training, and then just how to interact with people that are different from you. And I know that may be an oversimplification, but in my opinion, it's the simple things that create the biggest results.
And COVID presents us an opportunity. COVID is really the floor. We have reached the bottom. We can only go up, and we have to go up. And Build Back Better has to come to our neighborhoods, not at the end when there's only crumbs left. There have to be investments early on, because we are a national asset, and we are the most untapped segment of the USA's population. And we have to recognize that, and we have to feel good about ourselves, and we have to get the opportunities that are here, and they are here for us.
I'd like to add who teaches this kind of structural and cultural component. And I think that teachers and caregivers, patients and caregivers are amazing teachers. When I was a medical student, I was so officious and I was so proud of myself. I sat with a patient one day and I said, oh, well, about 3% of patients experience this, and only about 5% of patients experience that. And my patient reached across and touched my hand. She said, baby, you know, if it happens to me, it's 100%. And so, I realized that I was doing doctor speak, and what I really needed to do was to learn relevance. What would be relevant to her. And so I think that patients introduced into the teaching role, and that we become askers as healthcare professionals instead of tellers all the time. And then, last but not least, I think taking education to the streets, if you would, so that right now our healthcare system is really all about us going to where the healthcare is. But I'd be right on, at the Dollar Tree, providing education, making sure that people, that you're also seeing people where they live, understanding what they're experiencing every day. And I have to tell one more story, because this was like just 10 years ago, and I thought I kind of knew. We went on a listening tour around the country. We were sitting in a church basement in a health ministry, and we were asking questions. And a woman was telling us how much she loved her doctor and how she trusted him. And she just went on and on. And then someone asked her how she was doing. She said, well, not so well. They asked her about her medicine, and she said, oh, no, I can't take that. And so we took a break out in the hallway. We were problem solving. Oh, this is what we need to do about adherence. We need to do this with her and that with her. And when we went back into the room, somebody, the smartest one apparently in the room, asked her the question, ma'am, why don't you take your medicine? She said, oh, because I can't get it. I can get to my doctor on the 20 bus, but I have to take the 22 to get to the pharmacy, and that ain't safe. Mm-hmm. So, I think that we have to teach members of the healthcare community. Who we learn from, I think, are our patients and community members, who can really help us truly understand and become culturally competent. We have a ways to go on that.
Definitely. I was on a council yesterday with some sickle cell advocates, and one of the amazing advocates there said, we always talk about access to care for the patient, but what about the patient's ability and access to get to the care? And we always forget the because we don't always talk about transportation. We don't always talk about that two-way communication with the patient. Oftentimes in healthcare, we're talking at individuals and not listening to them. There was a really great example of a disparity that was evident in my area of Florida. So I'm from South Florida, near the Glade, and if anyone knows anything about Belle Glade and that area, oftentimes these are very poor populations that don't even have access to running water at times or electricity. And someone was asking a patient who had really poor outcomes, diabetes outcomes, why aren't you taking your insulin? One, the insulin had to be refrigerated. They don't have a refrigerator. And so what the public health department did is made some community centers where there was a shared space for refrigeration, and there was a dedicated community health worker there who would be able to log their medications in, because yes, you could get access to this insulin, but the insulin would expire because it wasn't properly stored. And so it's really important, as we talk about the social determinants of health, where a person eat, plays, prays, works, etc., that Ms. West had mentioned earlier, to really overcome these disparities in health. But getting back to the question I was asking about how do we really address healthcare, I'm really privileged to be part of the Accreditation Council for Continuing Medical Education, ACCME's task force on diversity, equity, and inclusion. And one of the tasks that we're really looking at is how can we further the ideas of DEI in healthcare, really for all those members who provide CME hours, continuing medical education, to really address the issues of racism in medicine. And so we're still working on that. So to be TBD on some of those strategies, but you guys have all hit your nail on the head on some of those. I think it's really important that we take people to community. I think it's also important, and you somewhat touched upon patients as educators, but I think it's really important to look at the education system in healthcare. I decided after finishing my degree that I was going to go back to a predominantly white institution and be an adjunct professor, because when I attended a predominantly white institution, and even some of the HBCUs that I attended in my career, I didn't see a lot of physicians that looked like me. I did see a lot of physicians that were minorities, but they didn't look like me. They didn't have my lived experience. And I think sharing those stories, sharing those lived experience can help shape the next healthcare workforce. So the kind of piggybacking off that conversation, what kinds of systemic changes can we make to the medical field to really keep implicit biases and racism from killing of these medical professionals from killing their Black patients? Do we need to hold them more accountable? What are some of those things? I saw a recent Twitter post by Attorney Crump, who was talking about a young woman who's polycystic ovarian was basically ignored by the physicians, and it led to some really detrimental impacts on her. But we're just not believed when we go into the healthcare setting. What are the systemic changes that you feel we need to address to really improve Black health?
Well, what just crossed my mind, as strange as it may seem, is what would it be like if I walked into my doctor's office, whatever doctor it may be, and they had a label on, not the hello label, but I treat my patients the way I would want my mother treated, or me treated, or my children treated. What difference would that make? And if I had one that says, I want you to treat me as well as, something to trigger that mind to, I'm not asking for something out of the ordinary. Treat me the way you want to be treated.
I like that idea of a designation where when you go into a physician, you know that they've received, cultural competency training. They are not going to practice implicit bias. That's a wonderful one for that.
Can I talk about data for a minute?
Yeah,
Sure.
thank you.
Because I think listening is one form of getting data, but our system is really in want of some more expansive, extensive, and data sets that we can use to figure out who has gotten care, what kind of care they have. And I think there's an opportunity to query data and ask the questions that we as healthcare providers and those who make decisions in the system. But I think we also have the opportunity and the obligation to see what questions patients have about their care and about their outcomes that would allow us to then modify, right? So our grades, if you would, in terms of patients' outcomes, are staring us in the face. And we have an opportunity to do a better job of understanding those and then responding to them. And I'll add on to that clinical trials and clinical trial diversity, which I'd like to come back to in a couple minutes. But I think Carlos leaned forward and had a comment to make.
No, it's centered around data, utilizing the data to help inform strategy. So I think you hit on it, and again, not to regurgitate, but I think data is going to be important. But something, Latasha, that you said earlier, in relation to the question you asked earlier about how do we solve some of those systemic issues. First of all, we have to admit that there is a problem. Too many folks are saying there isn't a system, there isn't a problem in our system, and you guys are making this up, and you're being overly sensitive. But if we can't admit that there is an issue, that there is systemic racism, that there is disparity in healthcare and treatment protocols, then we're never going to solve it, because we're going to have this divide saying, it's not happening, this saying it is happening, and we're at a standstill. So we have to admit it. It's like anything else dealing with diversity, equity, and inclusion. The glass ceiling. People said for many years the glass ceiling doesn't exist. There is no glass ceiling. Women are just being overly sensitive. Well, we knew there was a glass ceiling. And once we admitted that and started addressing it, we started to see some growth in women moving up into the C-suite. Still at a slow pace, but it's moving. It's the same thing with what we're dealing with in health disparities. As long as we're denying it, we're not going to move this forward.
And I yes, exclamation point, confetti throw. I mean, I really think that we have an opportunity to be able to ask and answer questions, but we do need the data. And COVID, again, shined so many lights on so many things. Right. One of them was kind of the paucity of data and the need for us to strengthen it profoundly, and then to ask the hard questions of it so that we can be responsive and make change. And I'll say, I have a friend, you talked about the healthcare system. system and the data that underlies it. I have a friend, every time I say healthcare system, she says, why do you say that? And I say, well, why shouldn't I? She said, because we ain't healthy, nobody cares, and it show ain't no system. And I ardently disagree with the middle. I think a lot of people care, and we're working very hard on improving and expanding the system to be fit for purpose to meet our needs. But I think we do have a way to go, and I think data will help us get there.
Think about how the system is changing. When you look up the number, and data has to be collected on this too, the individual practices that are being brought up by hospitals. And where will that leave all of us? In a monopoly of healthcare? And if we weren't surviving well in individuals, how do we go about surviving well in a monopolized healthcare system?
Definitely.
Yeah.
And it's real. It's so real.
So for that, isn't that the $1 million question across the board, even whether it's healthcare, poverty, education? You know, how do we overcome that monopolized system in all of those areas?
But you know we can. We are a powerful people. Look who's the president.
Okay.
And why I mention the president is the president also needs to address the nation during prime time with regard to the COVID situation. We hear bits and pieces and part of other talks, but we need that Oval Office and the messengers from people at the community level that look like the people, as well as vaccinations and testing and everything else at no wrong door.
Latasha?
So it would be remiss of me if not to mention, make a remark on the data aspect. I know if Dr. Puckram was here, he would share, some of the work that NMQF has done in this space. So NMQF has been collecting data over about 20 years now and has over 5 billion patient records across, I think it's 2,300 health conditions, and tracks the health of individuals in the Medicare and Medicaid space, so covering all of the various conditions. And those are some of the things that really drive what we do at the organization. And, Dr. Lewis Hall, to your point about a healthcare system, it actually is a sick care system. And NMQF's mission has recently changed to really address that. We feel that really addressing patient risk and not financial risk will help to improve outcomes for all of our communities, because right now in the U.S. we focus so much on financial risk, how to reduce costs, how to change the payment paradigm in healthcare, but that's not putting the patient at the center. And Dr. Lewis Hall, I know you spent a lot of time at PCORI, and I focused much of my career on patient-centeredness, and so I want to kind of go back in terms of patient-centeredness and talk about clinical trials and how do we ensure diversity in clinical trials? How do we ensure that clinical trials are patient-centric and address a number of the issues that Fredette as well as Carlos brought about in terms of going to where the people are, because a lot of clinical trials really don't. We were fortunate during this pandemic to see that there was diversity in some of the clinical trials, but how do we ensure that that continues post-pandemic?
Well, I think there were so many lessons learned in COVID, especially, in so many dimensions, but in clinical trials specifically. For years and years and years, it's been, we can't find investigators, and the patients don't trust us and they don't want to come. And, there were all of these logistics issues that were pointed to. There's been a lot of talk recently about community-based clinical trial environments or infrastructures. So what happens when you do take the clinical trial environment to where patients are? I'm really excited about a project that's ongoing now from pharma that is actually looking at a demonstration or a pilot on clinical trial infrastructure that's community-based. And it's based on Carlos's earlier point, which is this is not about one organization, institution, or individual. It's really about extensive partnering in order to get into the community with the community and patient focus. And patients from the start, what are the right questions? How do the protocols advance? How do they meet my needs as a patient? Have you thought about all of the logistics that are involved? I think we have a lot of work to do, but it's started and starting, and I'm really anxious to see how this program, as well as the other areas of focus, are progressing.
Now, what I tend to say to people in general is, believe it or not, we're in one large, massive, nationwide clinical trial right now with our vaccines. And look how well it is doing us. And the actual data needs to be collected. Some of the questions have not even been phrased that need to be phrased in order to capture the right data. And when I say that to people and they think about it, it's like, we are. Because each of us have our own experience with COVID vaccines. But we're still looking to encourage others because we want to. I would be remiss not to say this. Too often, we allow media and others to dictate who our leaders are. Notice how long we have talked. And even though I've written it on this paper, and I should have said it a long time ago, Black Lives Matter, vaccines work. Too often media has now, since election, don't want to mention Black lives. Black lives matter. Black lives do matter, and they matter in vaccinations too.
Great. So I see our time is ending. I do want to allow you each to leave one last remark about kind of the state of Black health in America and what your vision for the future would be. I'll start with Fredette.
I envision a healthier America, and a healthier Black community, that we are believed when we do come to you as a healthcare provider, that you don't try to interpret what I'm saying to you. Believe what I'm saying to you. I don't need you to reinterpret it, but I need you to understand what I'm saying to you and be the best healthcare provider you can be to me as possible.
Thank you. Carlos?
I think for us is this, that we want to continue to make, healthcare affordable, accessible, and to give people the information and knowledge to make informed decisions about how they go about their healthcare. People are ultimately going to make their own decisions, but we want to give them the tools and educate them and equip them with the tools to make those decisions. And as Fredette said, we want a healthy, happier America. And those are kind of the goals of my company.
And Dr. Lewis Hall?
I believe that we can and will achieve health equity. That is the ability of every person to reach their full health potential, unimpaired, cultural or structural issues, each of us there. And I have to, I never miss an opportunity to quote my mother. COVID has been an incredible storm. And my mother used to say, don't let the storm distract you from your journey. Let it clear your path. And I think that we have a path that is clearing, our aperture is opening, and health equity is within our reach.
Great, thank you.
Just a quick one. Before we leave here, the fact that you invited us here and the chairman did, we have additional responsibility to maximize what we do. And Carlos, I have a partner for you.
Let's talk.
Okay.
So my last remarks, I'm actually going to give two because Vanessa reminded me of one. So I am really pleased to be at NMQF partnering with the Congressional Black Caucus Institute on a partnership around trusted voices during this pandemic. So through a grant from Kaiser Permanente, we are working with 12 African American community-based organizations, the majority of which are federally qualified health centers, to really leverage the community voice during this time to share with them information, drive action to really address the pandemic in their communities. This effort you can find out more about on our website, as well as look at our index called the COVID-19 Index, where you can see the areas in which these communities are and see the impact of COVID in those communities, both in the past, and we also use predictive analytics to look at it in the future. And we've created what we call microsites and COVID diaries, because no one was capturing the stories of these partners during this pandemic. That's lessons learned. And so my closing remark is I feel through partnerships and collaborations, again, that we can reach health equity. And I really believe in a Adinkra symbol from West Africa called Sankofa. We have to reach back and fetch it in order to bring about the changes we need to see. We need to, as we get to the places we are in our careers, reach back and help one come forward. Mentorship is going to be truly important. So with that, I want to thank you all for this very informative discussion today. And I want to pass things over to Vanessa and CBCI to really close out today's conversation.
Thank you.
Thank you.
Thank you all for joining us today. Special thanks to all of our panelists and special thanks to the audience for tuning in. I hope that this has been informative and that you leave feeling informed, inspired, and ignited. Please join us tomorrow as Soledad O'Brien will delve into African Americans in law enforcement. We hope that you will join us and we look forward to seeing you. Thank you.